Okay, good morning, everyone. So it's another Monday, 6:30, very important class. What are the barriers and what is the need of advanced care planning communication amongst healthcare professionals? And this class will be taken by Mahatma Gandhi Cancer Hospital and Research Center at Jaipur, and the program Palliative Care Program, which is leading by uh, a team of doctors, and Dr. Nipun is a young palliative care physician who is associate professor in this department, and I have seen him. He is working so passionately since last many years to develop this department, uh, and also in a private medical college they are having all sorts of best practices which a palliative care department should follow, and they are following. So, Dr. Nipun is, as I told you, that he is an associate professor, and he did fellowship in pain management, palliative care, and various courses in palliative care. Uh, he is also coordinator of all our palliative care courses, which is happening in Mahatma Gandhi, which they are also conducting essentials of basics in palliative care program in their hospital, and they are doing good advocacy by teaching and training young doctors and nurses. His area of interest are pain management and palliative care. So what I will request Nipun to introduce Richa Randhawa. Richa is their young palliative care young palliative care resident from our their department. I will request Nipun to introduce Richa and then start the plan. You can write down your questions in the chat box. We will take it after at the end. Go ahead, Nipun. Thank you, Nipun.
Good morning, madam, and good morning to all. Thank you for the introduction. Ma'am, Dr. Richa Randhawa is our second year PG resident in palliative medicine. She is very enthusiastic and very good in communication as well as talking to patients and relatives. So this topic particularly is very well suited for her, and she is very hardworking resident. And she has prepared this presentation from various our textbooks like Oxford textbook and other journals, and tried to get the best version from all the books and journals. So I will now request Dr. Richa Randhawa to please start with the lecture.
Okay. Thank you so much, sir, for such a kind introduction. So good morning, everyone. My topic is needs and barriers in advanced care planning communication among healthcare professionals. Under this heading, I'm going to be covering all these topics. Now, talking about future illness, death, and dying can be very difficult for many people, as it may unleash strong emotions which are going to prevent effective communication. As some people are very resistant to planning for the future, like they have an unrealistic perception that I'm not going to die as soon because I'm too young to die. They're afraid what might be told to them. And they feel that the healthcare professionals doesn't have time for them. They're not interested to listen to their aspect of story. Whenever a patient doesn't want to have any conversation in advanced care planning, we should respect the person's choice. Now coming to some basic definitions. What is advanced care planning? Advanced care planning enables individuals to define their goals and preferences for future treatment and care. Like what matters to me? What will happen when I'm not able to speak for myself? And to discuss these goals and preferences with the family and healthcare providers. To record and review these preferences if appropriate. Plus, it also covers physical, psychological, social, and spiritual concerns of the patient. So in a nutshell, it is going to encourage an individual to identify a personal representative who is going to represent his beliefs, values, and preferences, and to record and regularly review these preferences. Periodically, it should occur within 1 year, or whenever there is any change in medical condition of the patient, we should review it so that their preferences can be taken into account should they at some point be unable to make their own decisions. What is advance directives? Advance directives, these are legal documents which are going to help you to provide what type and extent of medical care you would need There are various forms available online which you need to fill. So it consists of a living will, which is going to describe your medical wishes, and a medical power of attorney, which is going to appoint a healthcare person who's going to make decisions on your behalf. What's the living will? A living will is an advance directive, which is going to tell about the medical treatment you wish to receive when you're not able to communicate. Plus, it's going to become legal as soon as you are going to sign it and a witness is going to sign it. Then second, come into action when you're not able to speak for yourself. What's the medical power of attorney? Medical power of attorney allows you to select a person whom you're going to trust that he's going to speak for yourself when temporarily or permanently you're not able to make your decisions. It can also be known as a healthcare agent, surrogate, attorney in fact, or a healthcare proxy. Now, what is policed? Policed is a physician orders for life-sustaining treatment. It's a written medical order from a physician, a nurse practitioner, or a physician assistant. So what is it? It is basically based on the patient's current medical condition and preferences. In any of such column is left empty, this means that full medical treatment is given to that patient. And according to the change in condition of the patient, changes can be made in this form. So now, first write the basic details of the patient. Then, when the patient doesn't have any pulse or he's not breathing, then mark attempt for resuscitation or DNR. Then medical interventions, when the person has pulse and he is breathing. So what sort of care he wants? First is comfort care. That is allows natural death. Provide symptomatic management to the patient. Then basic medical treatment. Antibiotics, medical treatments, IV fluids, cardiac monitoring, but don't go for mechanical ventilation or any invasive treatment. Then full treatment, that is invasive treatment, admit in ICU. Then in C column, there is artificially administered nutrition. D is documentation of discussion, that whether the patient has told all this. If there is a minor patient, then the guardian, court-appointed guardian, a healthcare representative, any surrogate decision maker. Then there's signature who's giving all these details, a patient or a surrogate. Even it should be signed by a physician. Now, basically, advanced care planning is done when the patient is medically sound and comfortable, which is going to further result in advanced directive, which is written. It can be in form of values or instructional. And this advanced care directive is going to come into action when you're not able to communicate for yourself. Now, advanced care planning, when it should be done, who's going to perform it, and how it will be done. Now, when should advanced care planning be introduced? It should be introduced in our routine as a part of normal healthcare system. Early incorporation is going to enhance the experience of the patient rather than such conversations which are usually indulged in end-of-life care. So, person should be medically stable and comfortable, ideally accompanied with a substitute decision maker, a family, or a caregiver. Who should perform it? So remember, advanced care planning is not just a single person approach. Rather, it's a team approach. So first, it should include the person himself. Then second, their close family and friends. The substitute decision maker need not to be a family member. Caregivers, aged care workers, nurses, doctors, healthcare professionals, and even organizations can take part. Now, who will take your decisions when you're not able to speak for yourself? First is 18 years or above, need not to be a family member. Who will listen, discuss your values and preferences and beliefs, whom you trust that he is willing to take the responsibility and is available when he needs to make the decision in a stressful condition. Now, what are the benefits of advanced care planning? First, it helps you to receive a care which is according to your beliefs, values, and preferences. Then it's going to lessen the stress, anxiety, and depression in your loved ones who are going to make decisions on your behalf. Then reduce non-beneficial transfer of acute care and unwanted interventions. It improves end-of-life care and person satisfaction with the care. Now, what are the steps of advanced care planning? First, think about what are your beliefs, values, and preferences. Think that when I have entered in an advanced illness, what sort of a treatment I will want? Will I want a treatment which is going to leave me in a condition when I'm not able to speak for myself? What are the various possible side effects of the medical treatment which I'm going to receive? In that state, where I want to die? In a hospital? I want my spiritual concerns to be taken care of, or I want to die with my family. Then think about that who will speak for me. Then learn. Learn about your current medical condition so that you can better understand that what is your health condition right now. Then decide. Decide on a substitute decision maker. It need not to be just a one person. There can be more than one person. Then talk to that person about your values, beliefs. Then record. The record need not to be just in a form of a written document. You can just have a conversation, or you can write a poem, you can write a letter, audio recording, or any video recording. Now, this is an advanced care planning continuum. Always remember, there is no one-size-fits-all formula for advanced care planning. Rather, it's a series of careful thought process and communication. It should start as early as 18 years of age. Complete your advanced directive. Then update periodically, usually within 1 year or according to your change in medical condition. Now, when the person has entered into end-of-life care, he's having any serious illness, he's not able to speak for himself, then a polished form will be filled according to his advanced directive by a physician, a nurse practitioner, or any of his assistant, and his treatment wishes will be honored. Now, how healthcare professionals help with advanced care planning? By 3 things. Be open, be ready, be heard. So be open. Find out more that what is advanced care planning. Then encourage people to talk about their values, beliefs, and preferences. Now explain them that emergency situation can arise at any time. So they need to have a substitute decision maker. Be ready. Undertake training in advanced care planning so that you have a proper knowledge and improved skill to tackle with such situation. Then talk about person's beliefs, values, and life cares. Now be heard. Discuss with other relevant professionals, family, friends, and caregivers. Encourage people to write down their advanced directive and safely store it. Then encourage them to review them periodically, usually within a period of 1 year. Now, needs of advanced care planning. There are 2 types of things which I'm going to discuss. First is, there are some questions which you need to ask yourself that what's the need of advanced care planning. Second, there are some triggers for advanced care planning. So advanced care planning is going to decrease stress, burden, and anxiety in those people who are going to make decisions on your behalf when you're not able to speak. Plus, it's going to decrease medical providers' moral distress because they know that what their patient wants. So advanced care planning is going to identify, discuss, and document one's wishes. Plus, it's going to prevent unwanted hospitalization and increasing utilization of palliative and hospice services. It's going to decrease aggressive treatment, number and lengths of hospital stay, plus in-hospital deaths. It's going to reduce the cost of end-of-life care, higher completion rates of advanced directives, plus it's going to boost the effectiveness of end-of-life. Especially, it's very helpful in dementia patient that before their cognitive function is going to deteriorate, they are able to speak for themselves that this care I want. It's going to improve the patient outcome and experience related to their healthcare needs and increased goal-coordinated care. The need arises when you're going to ask yourself these questions. Would you accept treatment if it meant you could not recognize or talk to your loved ones? Would you accept treatment that might mean you were unable to drink or eat? Would you accept treatment if it meant you could no longer live independently in your own home? How would your cultural, religious, spiritual beliefs or traditions shape your healthcare preferences and choices of medical treatment? Would you accept treatment if you could no longer express your needs to those who are caring for you? Like, I need to go to the toilet. I want to sit in the garden. I have pain in back. Now, there are some triggers which are going to make you feel that now advanced care planning need to be done. First, when the patient has any advanced chronic illness like COPD or any heart failure, been diagnosed with dementia or has an episode of delirium, life-limiting illnesses like advanced cancer, is 55 or 75 years of age or even older, at risk of losing competence like has early dementia, any new significant diagnosis like metastatic disease or transient ischemic attack, a person who needs repeated hospitalization or is on oxygen, doesn't have anyone in the family who can make his decisions. Plus, in a person whom I would not be surprised if he dies within the next 12 months. So this is a scenario in which the person has entered into a life-limiting illness. Now the doctor asks his family that what sort of treatment he wants. There are two scenarios. In first scenario, the patient has never made his advanced care directives. He has never planned about his future. So nobody in the family knows that what he wants. He wanted to die die at home with his family members, but nobody knew. So his wishes were not reflected in the treatment. In second case, the patient has previously made his advanced care planning. So his family knows what his wishes were, and those were reflected in his treatment. Now, what are the barriers in advanced care planning communication? Barriers I'm going to be discussing in terms of patient, healthcare professionals, physician in ICU setting in terms of the knowledge, attitude, and practice, and system. Now, challenges. Implementing advanced care planning is very difficult and intimidating, especially in a typical 15-minute primary care visit setting, because it's an emotionally complex topic. Not all patients are willing to have such discussions. Plus, they do not have trust over the healthcare system. They do not have a strong relationship with the palliative care practitioner. It demands on clinicians' time because they don't have enough hours to do their normal jobs. How they're going to tackle with such an emotional topic? It's a fluid and evolving conversation. I'm sorry for this. Fine. Advanced care planning is seldom completed in just one sitting. According to, things change, their plan evolves. Plus, new life experiences and new technology also affect their decision making. Now, barriers to effective communication. In order to communicate with people in a way that is meaningful to them, we should know that what are the barriers. So barriers can be in terms of healthcare professionals or patients' point of view. Patient's barrier. There is an evidence that patients disclose as few as 40% of their concerns, which was studied by Heaven and McGurry in 1997. And those who are most anxious or most distressed disclose the least. So reasons for non-disclosure by the patients include, first is inability to cope. They have this fear of breaking down, having worst fears confirmed. They want to protect their family from this distressing news. Then their beliefs. They believe that healthcare professionals are too busy. They are not interested to listen. They are just interested in a certain aspect of care, that is curing the disease, not about their care. Then they feel that life depends on treatment, and complaining about this treatment, making some changes, it's going to lead to its withdrawal. They feel that their worries are insignificant. Some difficulties which the patient faces, they are unable to express themselves. They don't find the right words. They don't have command over the language. They feel that healthcare professionals is not asking relevant questions, that is open-ended questions. Now, some healthcare professional barriers. What they fear is, they feel that such sort of a conversation is going to upset the patient, which is going to unleash strong emotions. Now, how to deal with those emotions? If I'm going to deal with it, I'm going to take too much time. And I have a fear that I'm going to say something wrong to them, which is going to cause more harm than good. Then fear of being asked some difficult question like why this happened with me. Then they have belief that emotional problems are inevitable. And there is no point of having such discussions when there is no answers to such certain questions. It's not physicians' job to discuss such things, and having such discussions is going to falsely raise their expectations of the patient. Then inadequate skills. First is incomplete knowledge. about how to have the communication. They don't know what to say, what to speak. Then second, they are not able to integrate medical, psychological, and social spiritual agendas of the patient. They don't know how to move into and out of feelings and how to handle specific situations like end of life care. Then support. They feel that patients themselves don't have proper support for them. Even physicians also feel that I don't have proper support. I'm going to tackle with the situation. Then there is a conflict going on among the team. Now, physician-related barriers to communication towards end of life in intensive care. Usually, end-of-life care communications are dealt when the patient is entered into ICU. So I'm going to be discussing these barriers separately. Now, Robert Wood Johnson Foundation Critical Care Peer Workshop identified that 7 specific domains of palliative quality care indicators were there. Two such domains were: first domain, there is adequate communication with the patient and the family members, in which 13 quality indicators were identified. And in second, that is facilitating patient-centered decision-making, in which 10 quality indicators were identified. Now, barriers. All the barriers reported by ICU physicians were characterized by quality indicators as developed by Clark and colleagues, according to their knowledge, attitude, practice of physician. Strong evidence was found for 8 specific barriers all related to physicians' attitude. I'm going to be discussing all these quality indicators along with the barriers in the next few slides. The first quality indicator. We all know that end-of-life care discussions are usually not a single physician's job. It's an interdisciplinary team approach. So meet as an interdisciplinary team to discuss the patient's condition, clarify goals of treatment, identify the patient's and family needs and preferences. So what are the barriers in regards to physician knowledge? First is insufficient training in communication. They don't know what to say. They don't find the right words. Then clinician reluctance to use opioids or any sedatives because of the potential side effects. They lack education in palliative medicine. They don't know that palliative medicine is incorporated early in the treatment as soon as the diagnosis is made. And such conversations should start early for the better outcome of the patient. Then involvement of the surgeons because they do not understand the psychological condition of the patient. The barriers with regards to physician attitude, that is, there is lack of consensus among the treating team in making end-of-life care decisions. Plus, surgeons in the ICU don't want to give case to the members of the other clinical team. Physicians feel that what I have taken is the right decision, and they don't include patients' families' decisions as well. Now, barriers in regards to physician practice. Physician doesn't have sufficient time to deal with such topics, plus unavailability of the attending physician due to rotation. Now, quality indicator 2. Address conflicts among the clinical team before meeting with the patient and our family. Now, barriers in regards to physician knowledge is that there is lack of communication skills among the senior medical residents as well as their colleagues. Then there is a conflicting opinion about different attending physicians about the prognosis and treatment. Then surgeons' disagreement with the other consultant to accept with the futility of the treatment because they have a strong belief that ICU treatment is best treatment and the patient will be okay. Then barriers with respect to physicians' practice, which is hierarchy, basic problem. Then second is holistic views of the physician, which they lack. Then quality indicator 5, meet with the patient and a family on a regular basis to review patient status and to answer questions. So barrier regarding physician knowledge is there is no familiarity with the skilled and timely communication. Such communication should not start when the patient has entered into end-of-life care. Rather, it should be early. Then physician's attitude barrier is that they have a negative attitude towards those relatives who want a limitation of the treatment. Then quality indicator 6. Communicate all information to the patient and family, including distressing news in a very clear, sensitive, unhurried manner, and in an appropriate setting, following spike protocol. Barrier in regards to physician attitude is families thought that they don't understand what is end of life care practices, what is end of life care, that they should be available. They feel that family is not available for such sort of a discussion, and having such sort of a discussion is unnecessary with the relatives. The quality indicator 7. Clarify the patient's and family's understanding of the patient's condition and goals of care at the beginning and end of each meeting. Now we have to perform active listening. First, we should allow the patient to speak that what he understands about the disease, patient or his family members. Then we have to actively listen it. Then we have to decode that information. Then give our own output that what is the current medical condition of the patient to his family and friends. Then clarify all the questions which the patient or the family is asking from us. So which we are not doing. We do not check that the family members are able to understand what is the condition of the patient or not. We do not include patient's role in decision making, their family also. We do not include them. Now, quality indicator 10. Prepare the patient and family for dying process. Now, physician knowledge is they are not aware how to recognize that the person is about to die. No awareness of dying process. Plus, there is an unrealistic expectation about ICU treatment. Physician barrier in regards to physician attitude is palliative care input is limited to the very end of life care, rather it's false. It should be incorporated early when the diagnosis is made. And death is also usually not expected even when the patient is on maximal life support and his vitals are deteriorating. Physicians use certain language like medical jargons, which imply there is abandonment of the patient when the patient has entered into end of life. Then barriers in regards to physicians' practice. First, they lack to take initiative that whether we should proceed for end of life care or not. They don't have confidence. Second, they do not refer the patient to hospice center. Why? Because they feel that the patient's family is not understanding that the patient is dying. And rather, the communication is also not proper with the patient and the family to make them understand this as well. Now, quality indicator 11. Recognize the patient and family as a unit of care. So there is basically barrier regarding physician's attitude is there is uneasiness in dealing with the surrogate decision maker. Plus, family is thought that the family is not able to understand. Family was not considered available, and physician finds such a discussion unnecessary with the relatives. Now, quality indicator 15. Initiate advanced care planning with the patient and the family. Barriers with regards to physician attitude is they have negative opinion about advanced care planning. They have their own ethical values. Then barriers in regards to physician practices, they are not actively recommending the use of advanced directives to the patients, which should be incorporated in a routine practice. Now, quality indicator 16. Clarify and document the status of the patient's advanced directives. Barriers in regards to physician knowledge is they lack experience with advanced directives. So there should be a proper skill training to the physicians. The quality indicator 18. Clarify and document resuscitation orders. So barriers in regards to physician attitude is the physician is not aware that whether the patient wants DNR or not. Most physicians discuss this resuscitation thing when the patient has already entered into end of life care. Plus, family dynamics and legal concerns also affect physicians' decision making. Now, quality indicator 21. Establish and document clear, realistic, and appropriate goals of care in consultation with the patient and the family. Now, barriers in regards to physician knowledge is that they don't know how to deal with the families who are pressuring ICU teams for the limitation of the treatment because they feel that their patient is suffering. There is no awareness about the guidelines of the futile treatment. Insufficient training in communication that how to deal with such aggressive family members. Plus, there is lack of knowledge about ethical issues regarding end-of-life care. Then barriers in regards to physician attitude. No acceptance that the patient is dying. There is a conflict of opinion about prognosis. Surgeons want to continue with the life-sustaining treatment because they have trust over it. They think that the time spent with the family is waste of time and energy. There is no appropriate communication strategy. Rather, the family is more told than being asked. Then barriers in regards to physician practices, that physician considers family request for continued fertile treatment as a mandate, not as a part of normal communication. Then there is low confidence in taking the responsibility. Plus, postponing decision making until all the treatment options are exhausted. Now, quality indicator 22. Help the patient and the family assess the benefits and burdens of alternative treatment options as the patient's condition changes. So barriers in regards to physician knowledge is there is no proper familiarity with how to define the futility of the treatment. They're unable to communicate such things. Plus, they have no proper knowledge how to manage with such illnesses. Then barriers in regards to physician attitude is that physicians find it easier to carry on with the ongoing treatment rather than to have discussions about the alternative treatments available. Now, quality indicator 22. Forgo life-sustaining treatments in a way that ensures patient and family preferences are elicited. So barriers in regards to physician knowledge is there is no familiarity with the legal framework of end-of-life care. There is a wrong perception that law prohibits withdrawal of mechanical ventilation. There is no awareness of end-of-life care guidelines. Plus, insufficient clinical training is also a problem. Barriers in regards to physician attitude. There is a concern about omission of life-sustaining treatment and having end-of-life care discussions when the life support should be withdrawn. Physicians are concerned about the potential legal actions. Plus, they prefer their own ideas rather than incorporating patients' families' wishes, beliefs, and preferences. Barriers in regards to physicians' practice. First, they lack time and information how to initiate for such communication. And they feel that the aggressive treatment is justified. Why? Because patient is giving money and resources are available. There is no awareness about existence of advanced care directors or a living will. Plus, they don't take responsibility. They lack this initiative to withhold or withdraw treatment. The system-related factors are focus on treatment and cure, lack of coordination and structured approach to advanced care planning, unclear responsibilities considering the initiation of advanced care planning, lack of accessibility of documented goals and preferences, limited resources. The barriers related to healthcare system or external factors is, first is insufficient time. Then how to deal with such complicated topics. Plus, patient get different messages from the family physician and from other specialists. Now, readily access to such forms is also a problem, plus financial issues. So these are this is a table of barriers in advanced care planning and their potential solution, which I'm going to be discussing. Now, essential ways to overcome communication barriers. Always make communication in accordance to the need of the patient. Ensure proper feedback, that is active listening. Stay connected during the whole communication and understand what are the patient's values, beliefs, and hopes are. Do not hesitate to have this discussion with the colleagues. Be a good listener. Have complete knowledge and proper training in advanced care planning, disease, and end-of-life care. Give ample time. This sort of a communication needs half an hour or even more. It's not completed in just 15 minutes or so. Overcome cultural differences. Do not be in a hurry. Always adopt a multidisciplinary approach. It's not just a single physician's job. Always respect the patient's wishes. Explain all the pros and cons of the treatment and their outcome. Explain the futility of advanced treatment. Deal with empathy, not sympathy. Prepare family and relatives for grief and bereavement. Now, advanced care planning, policy, legislative, and judicial aspect in India. In India, Supreme Court first began weighing on constitutional basis of the right to die with dignity in 1996. The absolute right to refuse treatment, even at risk of death, was clearly stated in common cause judgment. A judicial functionary was thus made the authority for both verifying advance directives and their implementation by withholding or withdrawing life support. This became an impossible hurdle, and the 2018 judgment effectively remained inoperable. However, initiatives began to evolve guidelines and documents for end-of-life care, and most of the current authors were part of these, which included do not attempt resuscitation policy, draft end-of-life care legislation, a model advanced directives, and institutional guidelines. Simultaneously, advocacy efforts continued with the government and the courts. This led to a recent review by Supreme Court in January 2023, which has significantly eased this situation. Some key amendments were: an advanced medical directive may now be made in front of a notary or a gazetted officer. There is no need for it to be countersigned by a magistrate. For withdrawing life support, 2 committees need to be constituted by the hospital where the patient is admitted. There is no need for a district collector to be involved. Now, there are some myths regarding the advanced care planning. First is that when I'm going to become ill or I will be old, I'm going to have some sort of a discussions. No. Emergency condition can arise at any time. So you need to have a substitute decision maker by your side. Then my loved ones knows that what sort of a treatment I want. They know what I would like to prefer. No. 1 in 3 people will know what you want, not everyone. Then advanced care planning is going to only matter when I'm going to write it down on a paper. You can even have discussion with your loved ones that what I want, so that at the time when you need it, they are able to speak for you. Then you need a lawyer to create an advanced care planning. No. Advanced directive forms are available online. You can fill them. You don't need a lawyer for it. Now, once I'm going to put my plans in writing, I can change them. I can't change them. No, you can't change them. Now, according to your current medical conditions, even periodically, you can change them. Advanced care planning form. So this is an advanced care planning form, which is available online. First, you have to take undertaking. Then second, agent. Agent means a person who's going to make decision on your behalf when you're not able to speak for yourself, and his basic details. Then alternative agent means a person if the first person is not available for you, then that person can make decisions on your behalf. Then quality of life. Quality of life is that when I want this advanced care planning to come into action with my adequate pain management, first, I'm in a comatose situation. Second, in a confused state, that where I'm not able to understand or make my own decisions. Then second, I'm not able to talk clearly or move myself. I'm in a dependent position in all my daily activities. Then in end-stage illness. Now treatment. In treatment, you're going to check yes, means I want that treatment, and no, I don't want that treatment. So first is CPR. Then second is life support or other artificial support. Then treatment of new condition, like you want any surgery, antibiotics, blood transfusions, or any other treatment. Then tube feeding or IV fluids. Then any other information you want to give, organ donation. Then signature. The signature has first you have to sign it. Then second, by 2 witnesses. And those witnesses should not be your decision maker. Then it should be signed by a notary public. Now provide this copy to your physician. Even keep it safely with yourself and tell your family members that this is my copy. Give this copy to those people who are going to make decisions on your behalf, and always store it properly. Now conclusion. To summarize, under the spectrum of palliative care, advanced care planning is essential. Advanced care planning is the process of communication between individuals, families, and healthcare professionals to understand, discuss, and plan future healthcare decisions in event that the individual loses his capacity to do so. There is a need for increased training and knowledge to have more positive attitude and greater confidence among the healthcare professionals. Advanced care planning is a priority for healthcare system around the world, seeking to preserve a patient's autonomy in times of incapacity and provide clinicians with insight into the wishes, preferences, and values of patient. Plus, major role of government is towards shared decision-making model. What is this? First step is seeking participation. All should be included. First, interdisciplinary team, family, friends, even the patient, or any people he wants to be his substitute decision making. Then helping you to explore and compare other treatment options. Then assess what are your values, beliefs, and preferences are. Then reaching a decision with you, because it's an interdisciplinary approach. Then evaluating your decisions. Then the most common barrier identified by healthcare professional was lack of time. Because such sort of a communication is not, completed just within half an hour or even more. It may take a longer time. It may be that a fee-for-service model is better for promoting such sort of a discussion. And the important point was lack of education, which requires specific training in advanced care plan. Now, regarding physicians' knowledge, physicians' lack of training in skills related to communication with the patients, families, and colleagues, including communication futility or further treatment, act as a barrier. Regarding physicians' attitude, physicians focus on small percentage of people who are going to survive rather than on those people, which is a large group, who will not survive in spite of having adequate treatment. Then physician personal beliefs and values and their focus on technical parameters. They're given specially, they're trained basically to save the life of the patient, and they don't understand that the patient is actually dying. Then regarding physician practice, physicians lack confidence in taking responsibility and taking care of the dying patient. Thus, physician education and palliative care guidelines are needed to enhance knowledge, attitude, and practice regarding end-of-life care. So end-of-life decisions should not be made at the end of life. These are the references, and thank you. Have a nice day.
Hello. Hello, Richa.
Thank you, ma'am.
It was fantastic, Richa. You have
Thank you so
you
much.
have understood the subject well, and then you spoke so well.
Thank you so much, ma'am.
It was too good. I am
Thank
so proud of our residents. They are doing so well, and proud of the teachers, those who are making them understand so well. So,
Thank you so
Nipun,
much.
you want to say something, or then we will take the question answer every.
Ma'am, I think we can take the question answers. Everything has been well explained by her, so we can proceed to questions. So it was a good presentation, very well spoken by her.
Thank you.
So Richa, first comment you can read. Nandini, would you like to speak, because you have given such a fantastic comment to Richa? Please speak yourself, Nandini.
Good morning. I really like the way she made the presentation, full of confidence, and her voice, the tone and the rhythm, and she made it like a conversational style. So we had to listen to her. I didn't get distracted. So that was very nice. And the contents also, it's very clear she has done a lot of reading up to prepare this. Um, um, there is no major comment because she has given the theory very well. I was just wondering if IAPC could request, the different institutions about what are the current practices, because she presented polls and all that, but that is in the US. We don't have them in a systematic way, but we do have certain templates which IAPC has made available, and some of the institutions have, created their own practices. So would it be, it would be, I think, quite useful to hear from those who have created a system in place, and because sometimes we have to do it in a conversational style, it cannot be fully documented. And but we, for example, we have something called as goals of care documentation, so that it's done in a gentle manner, and it's not clearly called as advanced care directive, but it serves very well to help them come to that kind of thinking. Then there are, other ways of doing it, communications in serious illness. And then there are clear guidelines where the institution has created. So I don't know, it would be very useful to have the Indian scenario discussed, because all the things that were presented today, how it can be, kind of practiced and made applicable.
Thank you, Nandini. You have given a fantastic homework. We will do it from today only. We will start working on this. Excellent. Thank you very much, Nandini. Thank you. IAPC will do it. Don't worry. And we will start working and we will engage you for this. Thank you very much. So there is a very good comment from Dr. Meenakshi from IDR Cancer Institute. Dr. Meenakshi, can you open your mic and say yourself?
Good morning, ma'am. Yes, I just wanted to congratulate Dr. Richa on a very succinct presentation and very patient and just the correct amount of information. It wasn't exhaustive, so people can have clear take-home points. And from my center, I just wanted to just add what we practically face when we are going to have these conversations is that it's challenging to get all the treating teams, especially in an oncology center, when all three modalities of treatment have been incorporated, to get all three teams along with the palliative care physicians to initiate the conversations surrounding goals of care. That is the biggest challenge we face. Maybe other senior faculty in the forum can also comment on this. Thank you, madam.
Meenakshi, we will take the comments from all the faculty. Before that, Mausumi has got something to say. Mausumi, would you like to say? Mausumi? I can see your comment. It is Mausumi or Mausumi Bansali, or she must have left. Okay, so Jennifer, what exactly you want to ask?
Ma'am, thank you. Thank you, Richa, for this excellent.
Dr. Jennifer, there is a student also. Sorry, Dr. Jennifer. Okay.
Sorry, ma'am.
So, okay. Go ahead,
Okay.
Dr. Jennifer.
No. My question also was in first of all, congratulations, excellent, clear, very detailed presentation. My question also is little similar to what Dr. Nandini had mentioned. Do we have experience? Yes, we in palliative care, we do a lot of this ACP, and we gather information through communication quite early and document. But I just wanted to know if there is some experience from people here who've actually helped people do the ACP in a formal way and have been able to execute it.
So, Dr. Nandini and Dr. Jennifer and Meenakshi, everyone, it's like there is a need now that today we have realized that there is a need that we should have a formal way of our own way of doing and executing this. And I think this is, as Richa also explained, that every patient is going to be different. So, we are doing advanced care planning in lots of patients, but I can't say that this is uniform in all the patients, because but what we do, we discuss with them, we document everything on papers, and that's all. And we have two performer which are already actually in our palliative care ward we have one or two performer which we can share with you, which already which is automatically is in the form of advanced care planning. So we discuss with the patients and we fill those forms. So beside this, we have also DNR, DNI documents. I think this is also based on our ICMR document and other documents. We have created those documents. So everyone must be having all these, but the way we should document it is uniform in all the patients. But the way we talk is not uniform in all the patients, because that scenario, because we have to take care of the emotions, the psychology of the patient, relatives, everything. So documentation is uniform, but the way we present is depends on person to person or patient to patient and the such circumstances. And but as Dr. Jennifer has asked, whether you have experience in cancer patient, definitely we start planning long ahead, and we have a almost it is covered in almost in 99% of patient. But how do we do it? I think we that Nandini said that we should ask or everyone that what are their practice, and we should make a uniform document. So we will do it. Definitely
So,
we will do
Sushma, I would like to add here that, just as an experiment, one of my retired colleagues, she simply wrote an advanced care directive and tried to get it registered with the first class magistrate and, or notarized. They have no idea. Although it is all there in the law, these people who are supposed to sign it off or, have it documented and have it filed, they also need awareness. So although, there is a long way to go. Of course, this law
It's a
has
long way to
really
go.
been
Yeah,
changed. Yeah, but all these we may need to take up as an organization and
yes, yes.
slowly make the difference. It's just a matter of
We
time.
have to keep on educating our patients. We have to keep on educating ourselves first, and then keep on educating our patients. Yeah, this is important. So
No,
there
no.
is
The
one
lawmakers, the people in the system, they also don't know about this.
exactly
Not just the patients and us, but finally, according to the current current
lawmaker. So, yeah,
law, there is a place where all this needs to be filed, which can be
yeah,
retrieved later
yeah,
and activated when there is a withdrawal. So that whole system needs to be made aware.
yeah, yeah, definitely. So there is a question from Divya. Divya, can you open your mic and say ask question? We have 8 minutes.
Yes, ma'am. Very good morning. If we can just get a recapitulate of like how she's presented the recent advanced directives, if we could just get a comparison of what was the previous one and what is the current one that you're following, it will be very helpful, ma'am.
So Divya, would you like to answer this?
I remember a few, but there might be some mistakes. So, firstly, I think it was earlier, it was on the onus of the district magistrate that they have to do everything. Now they do not have to go to the district magistrate, but they can do it at the notary itself. And secondly, now they have formed the board of the ethical committee within the hospital, which can actually decide whether they can go with an advanced directive or not. Second thing was previously the relatives no previously it was the district magistrate who has to go in contact with the treating hospital or the treating physician regarding the patient's advanced directives, but now it is on the onus of the patient or their surrogate who is responsible for taking the directives notice to the treating physician, ma'am.
Very good, Divya. And we will share these. Very good, Richa. We will share all these slides, Divya. Just after finishing this, Archana will share. So you can see the slides also. Okay.
Sure, ma'am.
So there
Ma'am,
is one. Yeah.
also, the Blue Maple that we have and the AIMS Delhi end of life care framework that we have, they only talk regarding the end of life care, ma'am, or also a part of advanced directives?
So I think basically aims this thing is end of life care, but it is automatically practiced in a way that it doesn't happen end of life care. You, as you said in first or second slide, that if you have a proper advanced directive and based on the disease status, it may keep changing and document it properly, so there will be no need of advanced end of life care practice, and there will be no sharp this thing a blow on the patient of end of life care. So basically I can say that end of this aims policy is basically for end of life care, but automatically when we reach to end of life care, automatically advanced directive happens, and we don't go to magistrate or lawyer. We just document on the file that this is what patient has advised, and patient keep coming to the hospital, but that paper is always there. So Mm, uh, actually, we will do it, but no, there is a need. There is a need. There
Yes,
is
ma'am.
great need, and there is a lot of things we have to do. So we'll do it. So, Dr. Maya, would you like to say, Maya from Indore, say something?
No,
Maya,
ma'am. No, ma'am. Clear, ma'am.
everything is clear. So, Dr. Maya
Yes.
is saying that now it is very
No,
clear.
Sister Maya is here.
Okay, thank you. Thank you very much. So there are 5 minutes more. Nipun, would you like? I'm really happy, Nipun, but I want to say, I really want to congratulate. And I met Dr. Hemant Malhotra in ICC, and I congratulated the way your team is. I was little worried, but you are doing wonderful. And I think the way you are teaching and training your resident, it shows by this lecture that they are understanding the right concept and right things. So, Nipun, would you like to comment?
Ma'am, as such, no comments. I think the only thing is that advanced directives are difficult to practice in present scenario as compared to matlab, teach, because every patient has different attitude, every physician has different attitude. It will take its due course of time before we can form a uniform guidelines which can be implemented everywhere. Yes, we are doing advanced directives like you told, ma'am. On file, we are writing their wishes, and we are writing what the patient wishes are, what the family wishes are if patient is unable to speak for himself. But I think there should be more standardized protocols, and as the time passes, within I think few years, we will be able to have advanced care directives as a part of normal process for in day-to-day practice, and that will be the point where we will be actually able uh, to achieve what we call a dignified way to how to proceed when a medical emergency comes. And it will take certain time, but yes, we are there. We are slowly reaching there as a team, as a community of palliative physicians. We are working on it, and we will get there, ma'am, definitely.
Thank you, Nipun. Dr. Stanley has one comment. Dr. Stanley, can you speak
Yeah.
your mind?
Thank you. Thank you, Richa and Nipun, for that wonderful session. Very useful. Just to comment a few things. In 2014, there's already a written document and published document by the IAPC and the Indian Society of Critical Care Medicine. So I think that is a good starting point. And if all of us can look at it and see how we can make it more widespread and also incorporate other things, from US and other places where they've come up with more, specific documentation. So that is one thing. The second thing is that there are two barriers that we need to keep in mind. One is barriers of us as physicians. We don't accept the inevitability of death. When we have that acceptance, then the second, emphasis would become comfort in dying, to provide comfort in dying. But we just don't seem to accept that inevitability of death. And we need to understand that and look at that. And the third thing is that the advanced care planning can be expressed. Usually we used to ask the family what did they want, what did they wish, and then try to respect that wish. But now we have the advanced directives also, which is a written document. The other one can be an express document, but the advanced medical directive is a written legal document. And the important thing is that in the advanced directive, medical directive, is that you cannot demand treatment. You can refuse treatment, but you cannot demand. You cannot demand that I should be put on a ventilator, whatever it is. That is a clinical decision. So legally you cannot, but you can refuse, and that will stand. So those are the few barriers I wanted to express. Thank you so much. We have a wonderful session.
Thank you, Doctor. Thank you, Dr. Stanley. Thank you very much. And it is only 1 minute left. So thank you, everyone, for joining. And thank you, Richa, for such a fantastic session today. And thank you, Nipun. Thank you, Mahatma Gandhi team, the whole team. And Archana, Nisha, and all seniors, those who have commented and contributed. And thank you, Nandini, for giving us the good homework. Thanks a lot. Thank you very much. We will see you next Monday before 6:30.